on that end. All right. So, as Peter said, my name is Christian Deck. I am coming to you by way of CEU Creations, to really just kind of be able to provide you all with a quick hour on a lot of best practices. So when it comes to what we're doing here today with everyone here at LEG and CU Creations, like or LEG, so we really want to create something that is a lot of practical application, right? Because you're coming to this by way of all the different helping professions. I know we've had a lot of folks in the chat say where it is that they're coming from in terms of the physical location, but I'd love to hear in the chat just what credentialing, what background, what industry folks are coming from, and while you're doing that, I can just kind of give you a little bit more info on me. So I am. I am a social worker by trade. So I have received my clinical licensure, LCSW. I am licensed in Indiana as well as a few other states. And my day job, for what it's worth, is I am a full-time faculty member with the Indiana University School of Social Work. Okay, so lots of LMFTs. I'm seeing LAC. I'm seeing a lot of the. We've worked hard for our licensure. We've worked hard for our credentialing in the chat. It's so good to see all of our helping professionals coming from all across the board. So my vantage point for a lot of what it is that I am going to be speaking on is kind of coming through that social work lens. I'm going to give a couple notes on terminology here in a few slides, but I do want to share that I try to really make this as applicable as possible across the helping professions. I know we've got nurses here as well, psychiatrists, folks that are coming maybe from a different color and shade of what the helping profession may look like compared to where I come from. But for what it's worth, it's pretty applicable across the board. And like I said, being with the School of Social Work, I am working with masters or soon to be master's level clinicians within the social work profession. And I tell my students exactly the same thing. I want this to be applicable. I want this to be best practice. I want this to be something that you can take with you as you leave today's session or, today's class if it's something that we're doing on campus, right? So, and when it comes to telehealth and telebehavioral health, that is really my area of expertise. This is, and I know that sounds pretentious, but that's the way we say it in academia. People ask, "What's your area of expertise? Where are you a subject matter expert?" That's another term I don't like. But if I had to pick one, it would be how it is that we harness technology for the greater good, how it is that we can do the work that we do, and we've been trained on and we've been educated on and we've proven it time after time after time in the arena. How can we do that when we're not in that same physical location as the client or patient or whomever it is that you're working with, right? So we're going to be looking at this from an angle of, all right, what are the best practices? And when we do have those ethical dilemmas, like when it comes to risk management, emergency management, safety planning, things of that nature, what is it that we should consider? So part of the work that I do, part of the many hats that I wear outside of working for the university is I do a lot of these types of lectures and trainings and things of that nature with CEU Creations and a few others and conferences and such like that. But I do have a private practice as well. So a few years ago, I was kind of in a career. I don't want to say a lull, but I was just kind of aching for something more. Now, prior to working in higher ed, I had worked in child and family services in Indianapolis, Indiana. That's where I come to you from here today. And I did that for about 7 years. It was good work. It was tough work. I very much don't regret making the move to higher education, but I missed those interactions. So I went back, I got my clinical licensure. A colleague and I started a private practice, which is called VibeWell Connect, and it's completely online, it's completely telehealth, and it served a couple purposes. One, it relit that fire, it started to fill that cup that was kind of being ignored a little bit, it just unconsciously perhaps in my career. But it was giving me a lot of material to work with in the classroom. It was giving me a lot that I could say, this content that we're going over in class today, I actually was working with a client the other day on something similar to this, or I was working on something to kind of be able to, I don't know, work it into the curriculum a little bit. So you're probably going to get a little bit of that here today. And lastly, I have been published a few times when it comes to this type of work and really just again harnessing technology for the greater good. So, in the interest of time, I'll stop yakking about myself. So, today's objectives. We are going to be, again, staying in the telehealth space. So, how it is that we can provide services to individuals when we are not occupying that same physical location. That's essentially what the definition of telehealth is. And really what constitutes telehealth delivery, we'll be looking at that in depth. We will identify best practices for competent and ethical telehealth service delivery. We will learn to apply proper informed consent procedures specific to telemedicine, telehealth in that space, differentiate between risk management and emergency management, and assess client/patient suitability for telemental health services using practical screening considerations. So again, I want this to be applicable. I want this to be viewed as something that enhances your real world practice, and that's just my goal here. So what I will say is as well, it's important to know the information, but it's just as important to know how to apply it, right? That's why I like giving those kind of real world examples of, okay, here's something that I encountered, maybe something that you've encountered as well. So with that all to say, if you have any questions, throw them in the chat. Throw them in the Q&A. I'm kind of monitoring that. I know I'm kind of doing a speed run of this training. I typically do this as like an all day type of thing. So I'm giving you all the highlights, but I will try to be attentive to that chat, those questions, and I'm saving a little bit of time at the end to kind of go through those as well. So a couple questions that I've already received is what are your thoughts on AI? That's gonna take the whole hour. I have a love-hate relationship with AI. That's gonna come out a little bit here today. I think it's a tremendous tool, but at what cost, right? There's a lot going on with our environment and our world around us when we look at just how much energy it takes to power AI. I have some ethical dilemmas there, I think. And then what is the primary population that I work with in my private practice? Typically, I'm with young adults, folks looking to transition to the next phase of their life, whatever that journey looks like. If they're in a career rut, if they're looking to just kind of address their mental health concerns, kind of move forward in a way that they haven't maybe been equipped with the tools to do on their own. I like kind of walking that road with them. So I use a lot of CBT, DBT. I'm in the process of getting Imageria certified for EMDR. I'm looking forward to how it is that I can do that in a telehealth space. I have some good mentors who are doing the work in that regard. If you're an EMDR person and you've been doing it telehealth, I'd love to connect. Feel free to throw your info at me in the chat. But yeah, that's kind of the space that I occupy the most. So good questions. All right, so let's get into today's content, shall we? So a couple notes on terminology, and I'm gonna read here for a moment. If you see me looking off screen, I'm not distracted. I've got two screens. One's got the camera, one doesn't. So today's session is designed primarily for people working within the helping professions, and the term telemental health will be used to identify the use of ICTs, that's information and communication technologies, to deliver services and overcome barriers of time and space. Similar terms have been used by other helping professions such as e-social work, digital practice, technology-mediated practice, telebehavioral, telepsychiatry, telepsychology, telehealth. I could go on. And that's just to identify their version of telehealth. ICTs are simply devices used to connect to the internet. Phones, tablets, laptops, computers, whatever it is that you're using today to join us, that's an ICT. Using the internet, that's a piece of it as well. So really all encompassing kind of the infrastructure, the devices, the programs. It's all under that ICT umbrella, if that makes sense. Uh, in my practice, I use the term client. That's how I tend to prefer it. You may use the word patient. It's all interchangeable. Same with the term clinician, social worker, therapist, counselor, practitioner, case manager. These are going to be kind of used interchangeably. I try to stick with clinician or helping professional, if that makes sense. So, and I tend to stick with telehealth or telemental health or telebehavioral health, usually telehealth. I try to save syllables, if that makes sense. All right. So, Um, with that said, if what I was getting at with all this, if my terminology doesn't quite match the that of your profession, I do apologize for that. I want to be in alignment as close as possible, but we've just got such a charcuterie board of professionals here today, which is a beautiful thing. But I can't make it all happen at once, right? All right. So, what is telemental health? Well, the current definition from the NIH is the use of electronic information and telecommunication technologies to support long distance clinical healthcare, research encounters, patient and professional health related education, public health preparedness, public health and health education. So, in essence, again, it's we're overcoming time and well, not time. This is real time in this moment, but more physical barriers that allows us to utilize technology, harness technology, and give services or education, whatever it may look like, to folks who are in need of it and or wanting it, and have the means of being able to utilize the technology. So, um, essentially it's just the use of technology to engage in service delivery when we're not occupying that same physical space, right? So, on from my lens, again, I say this in respect to all of us that are coming from different professions, but again, I come from the land of social work, and if you are familiar, social work loves to put its own spin on things. We have our code of ethics, just as all of our professions do in some form or another. But one of the things we have kind of done specific to the field of social work is what's called e-social work practice. And I want to talk a little bit about kind of what that is, because it kind of philosophically explains where I land. Okay, so e-social work practice is essentially a subcategory under the larger telehealth umbrella that is in tune with kind of what I described, how it is that we can harness that technology for the greater good. And an aspect of e-social work practice is enhancing the availability of services, right? Digital services, access that communities can have to high-speed internet or devices that allow them to have this access. So I'll give an example from my practice of what it is that e-social work can look like. So a few years ago, within my role as a professor, one of my colleagues was in conversation with the Indiana University Center for Rural Engagement, and essentially what this group was looking to do, this consortium was looking to do, it was a collaboration between our school and the Center for Rural Engagement, and they said basically, Indiana, we're struggling when it comes to making mental health services accessible to community members, especially in rural communities, folks that may lack access to internet in their homes, high speed internet just in general, a vehicle to get to an appointment just being available, an office being available in their area, right? So we started kind of brainstorming, okay, what is a way, what is a resource or a space, a hub in the community that already exists that may be able to bridge this gap? And it's libraries. All Indiana has a very good public library system. Most states do, for that matter. But what we were able to do was we were able to partner with libraries across Indiana, starting in a small 5 county just spread, and create telesuites, which are these private rooms dedicated to individuals who are looking to sign up for them. And what they have is just a computer, a webcam, headset, microphone, earphones. Everything can be, really easily connected and private. It has a door that can shut. You can sign in, you can sign out. It can be used specifically for anything where a web session is needed. So that could be a job interview, that could be meeting with friends or family, even over webcam. But specific to what our school was offering was we needed, part of our kind of need in this scenario was our master's level students needed a place to practice their skills, to be in the arena and try things out and actually work with real life clients, right? So what we did was we housed 5 rotations of master's students for their practicum so that they could get hours, clinical hours, working with community members, basically providing soft skills, basically doing assessments, trying to get a feel for what it is that this person is needing help with, maybe doing some referral work, not doing therapy. They're not qualified to do that at this stage, even though some of them wanted to, like thought that's what they were doing. It's like, no, this is part of your learning experience. That's not what you're doing. But it was a beautiful thing. It was an absolutely beautiful concept that really just came out of an idea that was eventually funded through our lieutenant governor's office and is still in place today across most counties throughout our state. So, e-social work practice is essentially putting our heads together and trying to do something for the greater good using technology, harnessing that for the greater good. So that's just an example. I like sharing that one because it's a feel-good story. Because I think it just kind of helped all parties involved. And kind of my role in that was just I provided some clinical supervision for the students, just a space to do some one-on-ones and kind of debrief and all of that. So when it comes to being in a telehealth space, though, I think some folks get a little bit intimidated by the concept of I'm not in that same room. I'm not in that same environment, being able to observe all parts of the person in front of me, all the nonverbal communication, feel that energetic flow of conversation as well. Um, and it's not that you can't do these things via webcam, via audio only. It's just we have to switch the style up a little bit. Effective telehealth practice still requires a strong foundation in traditional clinical skills. You're just integrating technological competence. So, clinicians, you're wanting to balance communication and engagement strategies with the ability to assess client needs and navigate technology confidently. Now, in that initial session with somebody, it may be a little harder to get a feel for that technological competence on their end or confidence or comfort level. We're going to talk a little bit about that on a future slide here. But basically, you all come to the table already having a strong foundation for the clinical side of things. Really, it's just building familiarity and just a perceived competency in utilizing the technology in session, if that makes sense. So, when it comes to core skills, assessment, engagement, intervention, evaluation, those are all key. Going through those kind of stages of assessment and moving towards goal setting, moving towards intervention, setting up kind of like homework, things of that nature. It follows that same kind of clinical framework, right? We want to be good active communicators. We want to be able to have a good cohesive flow to the dialogue, and sometimes it feels a little weird doing it here, right? So we want to be mindful of our own biases and our own tendencies and just the things that we're a little bit anxious about. If this is feeling like we're a little bit of like a baby deer learning to walk for the first time, fish out of water, whatever kind of cliche you want to use. But what you can kind of do to really lean into that discomfort is know that, I know what I'm doing. I know what I'm doing when I'm meeting with people. I know what I'm doing when I'm in that shared space and honoring that space with them. It's relatively the same kind of practice guidelines as face-to-face service delivery. It's just, we gotta be familiar with kind of this scale of things. So, um, assessing our client's comfort level as well with the technology, that's something we want to be mindful of, and we want to be able to do in that initial session, like I was saying. So I'll give a little preview of how we can do that. So when we are meeting with somebody for the first time, if it is, telehealth, we want to ask them exactly that. Hey, is this your first time meeting with a provider? via webcam, via audio, whatever it is, and just allow them to kind of share with us. Or like, no, I got used to it during COVID. This is old hat. I've been meeting with people this way because I prefer it to everything that entails, the face to face. I like being able to do this from home, yada yada, whatever it may be. But for some folks, it may be, no, this is my first time, or I've tried it before. I had to have somebody help me kind of set up Zoom on my computer. I'm kind of, a little bit hesitant here. And, we lean into the strengths, right? We say, okay, hey, I hear you. That's totally valid. These things are complex. Here you are in the session right now. You were able to get in. Tell me though, scale of 0 to 10, how confident are you that you're going to be able to kind of navigate this technology moving forward after just with our sessions? Getting a real nice data point by asking that scaling question can be very powerful because a lot of times people would just give us like oh, I'm okay, or yeah, I'm pretty confident, whatever. I like knowing where somebody is um, on that scale just to avoid the subjective nature of I'm pretty good, I'm okay, I'm feeling all right. Because then at the end of the session, if it is something where maybe they're a little bit uncomfortable, maybe they said, I'm lower in that confidence scale, we can ask them again and say, hey, you did the whole thing, you did the entire session online. How are you feeling about it now? And maybe they are raised up a little bit. Maybe they're a little bit more confident. Maybe there were a ton of glitches and we just lean into that and the reality of it and we acknowledge it. But if they are a little bit higher, let's celebrate that. We'd be like, yeah, absolutely. So bookending a session by asking their confidence levels with technology or any questions they have about it. A lot of folks worry about encryption, confidentiality. So if it's not included in our informed consent, just kind of like the privacy policies, that's an excellent time at the beginning of a first telehealth session to just ask if they have any questions about any of that or if there's anything they'd like to speak on that's important to them about just the nature of how it is that we meet. That would be, a great time to do it. So, all right. Couple things about the benefits of technological integration in the service delivery world. I will say this, I do believe that while I am obviously your trainer, I'm somebody who's well versed in this space. I do believe that face-to-face is still the gold standard. I really do. There's just something about sharing a room, sharing again, that energetic exchange with an individual that you really can't beat, but that doesn't mean that you can't do this online, digitally, and still allow it to be a space where clinically important and evidence-based work is being done, right? So telehealth does translate well in the areas of addressing symptoms of anxiety, depression, PTSD, OCD, any type of like talk therapy, any type of space where we are able to utilize formalized assessment tools, things of that nature. We are in a good space for that in telehealth, and there's a lot of evidence that supports that within the research and the literature. So when we're looking at kind of the logistical pieces on your screen here on the um, right side, there's the convenience factor of it. It's more flexible in terms of just scheduling, less travel, less stress. I'm the type of person when I'm on the road, when I have to leave the house for any reason, it seems like for whatever unconscious energetic force that exists in me, I'm trying to get a treat. I'm trying to get a drink. I'm trying to grab a Celsius. I'm trying to grab something on the road. And so that it cuts down on cost, right? It cuts down transportation and just the undisciplined nature of me going out into the wild. But parking, meals, things of that nature. It's like I'm at home or I'm, doing this on my lunch break at work or, there's a lot of creativity that can kind of take place in that regard when it comes to cost saving measures, but also access. This is something that really can help support individuals who maybe aren't in a position to be able to physically transport themselves elsewhere to a session, either by way of physical disability. Maybe it's a barrier that is mentally constructed as well. If there's high anxiety in general, maybe we're kind of navigating aspects of that. It can be something that really allows people to access services in the comfort of their safe space as well. So when we integrate that into the support structure, we can really kind of do a little bit of wraparound work. I actually had a client that um, really suffered, I shouldn't say suffered, was working through some very difficult and long-standing social anxiety that kind of manifested out of the pandemic. They got very comfortable staying in the house to the point of never leaving the house, everything being delivered. And they recognized this isn't healthy. I need to get out of the house. So one of the things that we started doing just through our psychotherapy sessions was this individual, they lived in an apartment above a kind of small shop, a small grocery store like bodega, downtown setting. And I asked them, I was like, you know what? If we were to have a session that just starts in your apartment, and we were to essentially engage in exposure therapy. You've got your AirPods in, you're connected on your phone, and we're walking through the the motions and the steps needed for you to go buy yourself a drink at the bodega, go buy yourself a soda down there. Um, would you be open to that? And my client was so scared, but she was like, this is crazy. Like, can we do that? I'm like, yeah, we could do that. We can do that. We can make a goal of this. Do you want to? And they're like, absolutely. I consent. And it was, we wrote it out. We kind of wrote it out in the treatment plan, but we did that. And I was just kind of, with them, kind of coaching them through the like some breathing exercises and a little bit of um just checking in, a lot of checking in, and they did it, and they got back up to their apartment, and she said it was like, this is one of the like most empowering days I've had ever, and I thank you, and I know it's silly, but this is like so meaningful. I was like, no, it's not silly, and thank you for just validating the process, I guess. But like, no, this was a really creative use of telehealth, and I've met with clients who have chosen to do it like in a park or just someplace like kind of doing some nature therapy, a little bit of just like touching grass in session. I like kind of integrating a holistic mind body element to incorporating nature when we can, when appropriate. So telehealth can do that as well, right? So depending on the work that we're doing, the setting that we're doing it in. I know we're coming from a lot of different professions, and kind of when I'm speaking to my private practice, there's a lot of freedom of movement, I guess, in some regards. But I like being able to utilize telehealth in those settings. It does kind of create some freedom there. So, um, when we are preparing our telehealth sessions, it involves assessing the client's readiness for, receiving services, of course, like that tech comfort. We want to make sure that they have reliable technology. We want to address any privacy concerns. And when we identify those potential barriers early and we really, kind of pass the mic to them at the beginning and say, hey, is there anything that's important to you? Anything you have questions about? Anything you want to know more about, or I should know in regards to telehealth? We can really, by asking that open-ended question, build confidence and reduce disruption so that we can lock in on the work, right? Because telehealth is just the vehicle, the way that we're getting there. We want to address those concerns early on and not later. We don't want to just ignore it, and because if this isn't going to be the right vehicle to get them to where they need to go, we need to know that sooner rather than later. So a way that you can do this is a structured pre-screening process. So if you have intake forms, if you have like initial inquiries, things that folks have to fill out like in the client portal or the patient portal ahead of time, that could help just cut down on like the conversational space needed, kind of screen filter, if you will, and just make it a little bit more of an effective experience. Now, of course, in our informed consents, we do want to make sure that we are being very forthcoming in our expectations, right? So we are meeting via telehealth. How is it that that looks, when appropriate? I think somebody mentioned um, in the chat, sometimes our clients meet us in places that aren't exactly appropriate. I've had a number of clients who I very quickly realized that they're just like in their bed. Like they're just logging in and their head's on the pillow. And like, you're never going to see me do that, of course, because this is, I am a professional. I am in my office space. There's very minimal distractions for what it's worth. I don't have my camera on the like blurred focus today. Usually I do with my clients, but yeah, no, it's sometimes we have to reaffirm those expectations. So the more that we can put in our informed consent forms about just that, what it is that we are expecting of our clients, no show logistics, backup plans if technology fails, the more equipped we will be for kind of being prepared when something occurs in the moment, right? So backup options, typically for me, what I do is so I meet with my clients via Zoom, and if they or myself, we are experiencing just disconnections, calls dropping, one of us keeps popping in and out, or maybe both of us, who knows? It's happened before when we're both just simultaneously experiencing issues. We will try for my plan at least is we will try to reconnect for 5 minutes, and then if 5 minutes passes and I have not yet reestablished connection or they haven't reestablished connection, I will then call them on the number that they have provided as their cell phone. For just an audio only session. Now, with insurance, with billing, sometimes audio only can get a little tricky. So I don't want to say that's best practice for every helping profession. I just know in where I am licensed and by what credential I hold, that is an option as being reimbursable for insurance. And if you're doing self-pay, if it's all it's all good in that department. But yeah, just know kind of with your liability insurance as well, and the insurance companies that you're billing, just if that's okay. But all right. Another thing, just logistics. Confirming that the person on the other end can hear and see you okay as being kind of your intro to the call. That's a best practice. Okay, so part of ensuring that you are delivering competent telehealth practice is knowing the client's comfort level, like we talked about. Scaling question is a great way to do it, asking if they've used Zoom before, asking if they've done telehealth in general. It's just as important that you are comfortable with that as well. So the level of comfort can be influenced by a lot of different factors with the individual client, the setting that they're logging in from, if they're at work, if they're in their office. Sometimes they don't necessarily want to get into the nitty gritty, right? Because somebody could be ear hustling on the other side of the door. Um, a lot of times I have clients go to their car and not drive around, but they're, sitting in their car, air conditioning on it, or window cracked, whatever. They're comfortable. Um, but that's a pretty private setting for what it's worth. And you're kind of locked into that space. But individuals who maybe have a lot of roommates, family members living under the same roof, that could be difficult as well. So one of the things that we want to find in terms of suitability is the privacy on the client's end as best we can. So I advise my clients when they are meeting with me, if they want to use headphones, if they want to use AirPods, whatever, just so that the audio can stay local to their ears, that's a really good thing to do just for not only the privacy end of things, but man, having a microphone closer to the client's mouth than just on their laptop or on their computer or whatever, it does make a world of difference when it comes to being able to hear the inflection in their voice, the tone, the things that we maybe worry that we're going to lose a little bit of when we are doing telehealth compared to face, right? So when we are in, and I do that too as well. I try to wear headphones as much as I can just to keep that audio local because I am, this is a home office situation, and I broadcast that to my clients, and we'll watch a little video about that in a second. I don't want to spoil anything, but yeah, it's all about meeting the person where they're at. So goodness of fit with telehealth services, it can look different for everybody. And on our next slide, we're going to watch a short video that provided on just kind of like an example of this. I just kind of role play something for y'all. But one of the things that or some of the questions we want to be asking ourselves as clinicians is, what do clients expect from technology? Do they expect that this is going to be a smooth operation, that we're never going to have to troubleshoot? Do they expect me to be kind of that person who can also wear the IT person hat and be able to help them with that? Which really best practice is we need to be familiar enough with the software, with the program, with the portal, with the EHR, whatever it is that we're using, so that if we have to troubleshoot in session, we're able to, right? As best as we can. Um, what is the history for their use of technology? Is this something, again, that they're very familiar with? Have they grown up with an iPad in their hand from the moment of joining the party to today? Is this something that they can just kind of do in their sleep? Or are they very, this is kind of scary and uncharted territory? So asking those initial questions about their familiarity, it goes a long way with, again, how it is that we present, how it is that we can be there for them, meeting them where they're at, and really just not assuming anything. We don't want to assume just because they were able to get logged in that they've got this. It just takes a little extra effort on our end to ensure everything. Again, the cultural understandings that increase concerns about privacy can be a thing. Again, household members, people who are within earshot, if our client is just walking around in their house on their phone, just, everything I'm saying is going out there, that's not appropriate. That's something we gotta talk about. Because there's concerns with that, right? This is PHI, this is protected health information. This is why HIPAA exists as well. So we want to make sure that, again, in those informed consent procedures, we want to have it in writing, but also we want to be able to be in a position where we can have a conversation about it as far as the working relationship and just the logistics of how these sessions are constructed, right? So um, when it comes to the client, kind of the attributes that we're looking for, assessing, the comfort, seeing kind of where their digital literacy is. We don't want to be throwing out a lot of terms that maybe aren't, that are like inside baseball, and it's just like, wait, what's that mean? Like, so if I just kept saying ICTs over and over, a good chunk of you are going to not remember that that's information and communication technologies, which just basically means a phone or a computer, anything with internet capabilities, right? So instead of me saying ICTs this whole time, I've just been saying like phone or computer or whatever, right? Even though I gave you guys that disclaimer at the top. So we want to kind of, in terms of our digital literacy, our language, the way that we are presenting the conversation with the tech side, just keeping it, human to human. And as a clinician, we want to have those kind of soft skills to be able to make that conversation work, but also have a level of trust in the process, in the service delivery. Because for some folks, and I've seen in the chat a little bit, like we do face to face. Face to face is the gold standard for a reason, so we don't touch the other stuff, right? And that's okay. Again, you are maybe in a position where you are looking to get more training, more education on telehealth because it is a little bit of the unknown, right? And I mean, you're in the right place for that, right? You're doing what you should be doing as a lifelong learner. So, um, but we need to have a little bit of that buy-in, at least in ourselves, in our ability to be able to help people meet outcomes, to be able to do the work via this way of service delivery, right? So that buy-in, that trust in the process, at least I know what I'm capable of doing and I can make it happen here. That goes a long way as well. Plus, that can be something that may be palpable. From the client, if we're kind of approaching the service delivery style of telehealth as being a little bit, I'm not sure, maybe a little cynical, they're going to pick up on that and they're going to think, well, okay, if this person isn't a fan of how it is that we're meeting, is that going to impact the care and attention that I'm getting? Which we're all pros. I doubt it would, but it might. It might. You never know. It's a valid fear. I would maybe feel that way if a professional was saying that to me if I was receiving services, if I was on the other end of the camera. So we don't want to go into that avoidance space. We don't want to try to just escape the challenges rather than addressing them. So. All right, short video. This is an example of a first session introduction.
Hi, Claire. My name is Christian, and I am the telehealth counselor that you will be working with today. Can you hear and see me okay?
Yes, I can.
All right. Before we get started, could I see your driver's license really quick just to confirm that I'm meeting with the person I'm supposed to meet with? Perfect. Right on. Okay. So we are meeting via Zoom today. Have you ever met with a provider virtually to receive services before?
I am not.
Okay. If you were to gauge your comfort level with this type of technology on a scale of 1 to 10, where 1 is you're not really comfortable at all with this, and a 10 is you could do this in your sleep, where would you say you are on that scale?
Probably around a 7.
Okay, cool. So you didn't really have any problems getting logged in and getting set up today?
No.
All right. Well, I am working from my home office today, and there is no one else here with me. I can kind of pan around a little bit just to show you. This is just me here. And I do have my headphones and microphone in, so the audio is completely limited to my ears and it isn't being broadcasted throughout the house. If for some reason our video were to disconnect, you can rejoin me by clicking the link that you used to get into this session just a moment ago. And if we're still having trouble, I'll give you a call on the phone number that you listed in your intake packet. And I have that as 404-522-6730. Is that correct?
Yes.
Excellent.
Okay, that was not a real client. That's my wife. I did not pay her to do that. She asked for money. I didn't have any, but she did it anyway, pro bono. So shouts out to her. Shouts out to Claire. She did a great job. And I just want to address there are a lot of questions in the Q&A. I'm just gonna batch read them at the end. I'm gonna build a little bit of time. And if you haven't thrown a question in the Q&A, but you threw it in the chat, I'm probably not going to see it because this chat is popping. You guys are going off in there. This is beautiful. But yeah, throw it in the chat or throw it in the Q&A and I'll address it at the end. So yeah, lots of little best practices there. Holding the ID up to the camera, me panning around, uh, headphones, like, and just kind of taking the client by the hand a little bit, walking them through. Here's how this looks. We're very calm. Do you have any questions? How's your tech comfort level? Yeah, not too difficult to do, right? I think we're all capable. So a little bit of a shift, a little bit of a shift. I'm going through a lot of content here today, so I apologize for the sudden shift. But I want to talk a little bit about risk management versus emergency management. These are two different things. Essentially, risk management is what we do to help future Christian or future you, a future clinician, be in a good space if an emergency, if a crisis goes down, right? So risk management is preparing ourselves and setting up ourselves for success, doing safety planning, all those things, getting the relevant information. Emergency management is okay, it's an active crisis. Red flags are going off left and right. We have somebody on the other end with suicidal ideation, with intent, with a plan, or we have an active DV situation taking place. I've unfortunately been in both of those situations as a clinician where I have had to actively triage with emergency services at the client's location. And it all starts with being prepared and hoping that we never have to encounter that. We do a safety plan in the event that it does happen, but we hope that it does not, right? So when we are in that risk management phase, this is the proactive and ongoing planning for potential issues that may arise in telehealth practice. Some of these are more macro level, like confidentiality breaches, data security, things of that nature, compliance with HIPAA, that we put in our notice of privacy practices. So, information that our client gets before, excuse me, the session even begins, just an overview. Hey, this is how it works. Here's your informed consent. Can you sign off on this saying that you read it? That not only provides them with the information that is needed, but also covers our butts as well, right? I mean, just to be frank, this is there's a lot of moving parts with telehealth, right? So when I am meeting with clients, I use a program, I use a platform. It used to be called Power Diary. It's now called Zanda Health. It's Zanda. That is my weapon of choice when it comes to an electronic health platform, a client portal. And I'm not being paid by them to say this. This is just me sharing amongst friends. It does a very good job of providing my clients with a one-stop shop for how it is that they connect with our sessions, where it is that they schedule, they book their sessions, where my notes go and they can access old notes, and where they can pay for everything too. I like that. I like being able to keep it in one space. However, when we are using this platform, technically it's a third party, right? Technically it's a third party. We're also using Zoom, which is another layer of a third party. I do use an AI transcription software, which is an additional third party. Um, so I make sure that I am putting all of this information in that privacy practice notice at the very beginning so that my client understands that, there's a lot of moving parts here. It's all encrypted. It's all HIPAA compliant. Zoom is HIPAA compliant at the subscription level, as is everything that I mentioned. So I make sure that it's made abundantly clear that this is software that meets that standard, but also here are links that you can learn more straight from the source, straight from the websites of these entities. Um, and did I just say AI transcription software? I feel like everybody's ears are kind of burning when I say that. Let me talk about that just briefly. I only have so much time. We're going to get through everything, but I want to talk about that because I feel like that's relevant to a lot of folks in the room. Um, so the integration of this program, the program I use is called Busy AI, Bizzy AI, and it's integrated within that Zanda Health platform that I told you all about. What it does, it uses Amazon's model to record the audio. I know, here we go. He's talking about this. It records the audio of the session. It then transcribes that. So it creates a transcript of the dialogue between myself and my client. It then takes that transcription and uses the machine learning, the large language model algorithm, whatever it may be, to take that transcription and then formulate it into the note that I am choosing. So whether that's a SOAP note, whether that's just a simple progress note, whether that's an initial assessment, whether it's something that I built out that has certain criteria that I'm looking for with nuanced cases, and then it churns it out into a drafted note. It cuts down on a lot of time. That was kind of the initial appeal. But then my partner and I, who's also in higher education, we're asking the ethical questions. Okay, wait, if this is HIPAA compliant, if this is encrypted, when I'm giving you protected health information, doesn't the machine, doesn't the AI train on the data that's being put into it, right? And yes, it does. By most standards, what an AI model does is whatever goes into it helps the model get better, right? However, what we learned is that when this model is given a audio recording, turns it into a transcript, it's then curated into the note. The moment I finalize that note, it deletes everything, right? And I put trust in the manufacturers and the company and the folks that do the work to stand by that, right? But am I standing there watching it get deleted forever and it's not on the servers? No. So there's a little bit of hesitance there. There's a little bit of ethical, like, oh my gosh. But what my partner and I did was we didn't buy in on this right away. We did a lot of research just kind of on the side, because this is something that we both kind of uh, in the educational space and higher education and research is also just like we're genuinely drawn to learning more about these topics. Um, we found through our own kind of reading through it all that this was about as legit as it could be. Now, I could go on. I don't have the time to kind of speak on the choice to adopt AI, but when it comes to the notes that we're getting, it's a good first draft. it's good at putting together a first draft. I always go through, I know it's not the final draft. I make my edits, I do what I need to do. It doesn't fully replace the work that I'm doing, but it cuts back on, I would say, about 20-25 minutes of me doing a note per client. Um, so yeah, that's the state of that at the moment. It is an ethical piece though. So um, when it comes to the ethical considerations, no matter what it is that we're doing, no matter what type of work we find ourselves in, first and foremost, we follow the applicable laws, right? We know that the laws and the regulations that apply to in-person practice should not be ignored in a telehealth setting, like informed consent, like following HIPAA practices, like encryption, all the things that need to be taking place there. Typically, at least in my credential, the client must be physically located in the same state where I'm licensed. It doesn't need to be my same physical location, but so basically, I have to physically be located in a state where I'm licensed, and the client needs to be physically located in a state where I'm licensed. So, for example, if I'm licensed in Indiana and California, and my client is in California, physically, we're good. But if my client is located in Oregon and I'm not licensed in Oregon, but I'm licensed in Indiana, I'm physically in Indiana, it doesn't count because the client is not physically located in a state where I am. So, um, when it comes to self-competence, we talked about having the ability to troubleshoot as needed, being able to have a backup plan if technology fails. Um, Ensuring we have a private, secure space, the data, the connection, those things. Um, we also want to make sure that we're using devices that are dedicated for this. So I wouldn't be using my personal phone to text a client, right? I wouldn't, that's not how I do it. I wouldn't be using my personal computer to do the work. I have a laptop that's dedicated specifically for sessions. So sessions with my clients. So short
So
video
I went over
again.
your paperwork that you had filled out prior to meeting with me today, and there are a few little pieces of information I still need to collect from you before we get started. One of which is an emergency contact. If, say, for example, a medical emergency were to take place during one of our calls, is there anybody you would like me to contact in addition to your local paramedics, just to keep them informed of what took place?
Yes, my mom,
Okay, and what's your mom's name
Kelly,
and her phone number?
555-5555.
Perfect. And just kind of going over the little bits and pieces of things to cover before we get started. In terms of privacy and confidentiality, all of that will be observed throughout our sessions. No details of our conversations will be disclosed to an emergency contact. The only time I would need to break confidentiality would be if a crisis situation has emerged and you are at risk of hurting yourself or hurting anybody else. I'm obligated to alert local authorities as a mandated reporter. Does that make sense?
Yes.
Okay. And this is something standard for all of the clients we serve here at our organization, just to ensure everybody's safety. So just to confirm, you are comfortable with that and you do consent to receive services moving forward?
Yes.
Excellent.
Okay, so that was just a brief example, informed consent procedures. We've talked a lot about this. I'm just going to briefly just share, it sets the expectations for the client. It allows space for questions, or we want to allow space for questions. Um, and really, when it comes to the telehealth side of things, it's very easy for us to do a quick share screen as well if we need to. If we need to go into like read the fine print with our client, we can totally do that. So a couple key components for a telemental health informed consent. Obviously, the same things that we would look for in just a face-to-face informed consent. That they consent to receive the services. We explain what that therapeutic process looks like. We talk about the confidentiality guidelines, the potential risks, emergency plan. If there's a social media policy, if you don't want your clients adding you as a friend on Instagram or whatever, maybe put that in there. I do that. It saves an awkward conversation later. Um, Information about cost, payment policies, social encounters, just in general, termination, and then disclosure of AI tools. I think it absolutely needs to be in there. And this is another piece of my partner and I's choice to engage in the use of an AI tool. we give our clients the ability to opt out and still receive the services. So we updated our informed consent to include a specific little box that says if you do not if you're not comfortable with AI, we don't even say that. If you don't want your provider to be using the AI transcription tool, just check this box. They will not do it, and you'll still receive the services. So we want to give them the freedom of choice. Especially we saw the Pope. The Pope made a big comment about AI the other day. That's pretty crazy. Not crazy bad, but like just like wow, like we're at that kind of that point. And I think from a cultural standpoint, I think we're definitely having like an ethical dilemma moment with how powerful these tools are, but also just the choice to adopt, right? So we want to disclose that if it is something that's being utilized, but also if we have the freedom to, if we're in a position where we can allow for them to opt out, if that makes sense. I think that's the right move, I would say. So just in the interest of time, I'm going to just kind of briefly go over this one. So, providing services to clients goes beyond just meeting with them one on one. Asynchronous communication, whether that's through providing them with resources, providing them with a shared space where they can access notes, access resources, tools, whatever, that can be another way that we're kind of doing the work in the in between time. We can, again, harness that technology for the greater good. We can give them access to things like crisis lines. Of course, we're very familiar with crisis lines, right? Those hotlines, that's telehealth. That's phone is telehealth as well. We're utilizing technology. Um, and then using things like gamification. I'm a huge fan of wearables, having the Apple Watch. I wear the Whoop, if you know the Whoop. If you don't know now, you know. It's another type of wearable that does track like heart rate, can tell you if you're having a panic attack, things of that nature, gives you data, gives you stuff. So I'm a fan of integrating whatever we can as appropriate for the services that we're offering if we have that ability. So a couple best practices as we kind of get to the end of this portion of things and I get into the Q&A. Um, we talked about the comfort check, right? The bookending the session with the 0 to 10. How comfortable are we with utilizing technology? We talked about some privacy factors, maybe panning our camera around, showing our space if we're comfortable with it to demonstrate the confidentiality of the setting. Because just as I would like them to be in a space that's confidential, they'd probably like that for their provider too, as well. Um, Backgrounds, be mindful of what's in your background. Be mindful of the client's background as well. With me, I will share this. Just a little bit of like inside tips. So when it comes to lighting, all right, I use a ring light that is located right behind my camera, right on the other side here, because it's forward facing. It illuminates my face. When it's off, I'll even show you. When it's off, it kind of it's I'm a little bit shadowed. I'm a little bit, the reflection is coming off the top of my head, a little shiny up there. It's just, it's a little bit better like this. So call it an influencer light, call it whatever you want, but it's a circle with a light. It hooks up to a USB. You can buy it on Amazon for $10. Um, the chat feature also can be a really good tool. I was in a situation once where I was a little worried about the safety of my client in regards to other people in the space in the home. And rather than asking that aloud because they didn't have headphones in, I just typed it in the chat, and we were able to actually initiate a safety plan, initiate an exit from the home because it wasn't a good situation, all through us essentially having a very surface level session, but in the chat being like I've got 911 on speed dial. Like we're initiating an exit, right? So audio, you can wear headphones to improve the sound quality and your focus, and then professionalism. I like to be able to do multiple things at once. I have two monitors. I've been referencing my second monitor a lot here today, but one of the things that I do to just stay locked in is that I have everything available to me when it comes to the client's chart, past notes, all of that just off to the side if I need to reference it. Another thing I do You've probably seen this a little bit with my eye contact. So I try to keep my eyes at the center of my screen and up, like in the center top portion of my screen as much as possible, just so that it looks, like I'm emulating eye contact. It's good body language, right? So what I do is I position my client's video on my screen. I make it so that their video is in that top center portion of my screen. So right now, I'm not actually looking at my camera. I'm looking just below that, and that's where I'd be looking at my client, very much visually trying to stay locked in there, right? So couple little tips, tricks of the trade. Um, I hope this has been beneficial to y'all. I'm gonna go through. I'm not gonna get have enough time in the interest of our other presenters to get through every Q&A question. I'm gonna try to answer as many as I can. Um, what do you address PTSD specifically with veterans? I don't work with veterans specifically, but yeah, telehealth is a good space for that. Telehealth can be an absolutely powerful space for working with individuals with specifically veterans with PTSD. Um, is communicating with clients about their service plan via telephone only without video still considered telehealth? Yes, by definition, that is still telehealth. Is it billable? I don't know. You would have to look into that yourself, but that is by definition still telehealth. How does telehealth impact the older population who may not be tech savvy? Well, a lot of practice, a lot of patience, a lot of keeping things simple, right? Using familiar language, having tutorials, having somebody maybe walk them through it. But that's where it comes on us to really be that knowledgeable tech person, right? Being able to put on the IT person hat and walk somebody through it a little bit. YouTube tutorials are excellent. I used one to replace my dryer, fix my dryer one time. I have no experience fixing dryers. I have no business doing it, but I was able to do it just by watching somebody else do it on YouTube. I'm a visual learner. YouTube can be a good resource as well. Um, I often run into patients being unwilling to try virtual therapy but are unable to do it in person. They need some type of therapy. What tips do you have to encourage them to at least giving it a shot? Just tell them it takes a lot of courage. It's you lean into the discomfort, you listen to their reasons, you validate their reasons for not wanting to, but ask them ultimately, would you rather get the services or not get the services, right? And if I'm aware that, we have this level of apprehension, that we have these barriers maybe in place that, they're maybe even standing in their own way and they just need a little bit of a little bit of that hand holding and just explanation, that really goes a long way. So just asking the open-ended question, what specifically is worrying you about this? That can go a long way. So holding a little bit of space there, I think is best practice. Um, let's see. I'm trying to get the big ones. How do you manage distractions such as clients opening another tab or playing on their phone? I only work with people who like choose to work with me. So typically they're meeting with me because they really want to like do this. But if you're working with a client that maybe they aren't here by choice, or maybe you're working with youth, I mean, again, little gentle reminders, asking them to just stay engaged in the session. Again, putting it in the expectations from the start, putting it in writing, that can go a long way. That's a really good question. I like that one. Can you meet with clients if you are temporarily out of state but licensed in the state where the client is located? It depends on your license. For mine, no, I cannot. I wherever I am physically, I have to have a license in that state. So, like, for example, I'm going on vacation next week. I'm going to Gatlinburg, Tennessee with my in-laws. I have good in-laws, so I'm looking forward to this. Not that there's such thing as not good in-laws, but no, I don't have a Tennessee license, so I'm not able to just do a couple sessions on the side while I'm out there. So, Now I can communicate via email. I can, shoot a couple emails left and right, communicate that way with my clients. Like I can't, I'm not going to ghost them entirely if we're in crisis and I need to connect them with somebody on the other side. Because I'm willing to do that. If we're not, we set those boundaries, right? But yeah, no, I'm going to be out of state, so I can't do that. Um, can you address best practices for when suicidality shows up in any capacity in telehealth? Yes, I can. I'm going to do this briefly. This is going to be my last Q&A question. Sorry if I didn't get to you. So, if we do become aware that an individual is having thoughts, feelings, plans, whatever it may be, we lock in. All right, that's the priority now. Doesn't matter what the agenda was prior. We're making sure that their safety and their well-being is accounted for. Now, that goes back to risk management. We talked a little bit about this on a previous slide. We want to have a safety plan. We want to know where their physical location is. We want to be working with them. We want to keep them on the line. If it does become something where mandated reporting, if we need to, or get emergency services involved, we always want to keep that going in real time. Okay. So if I'm having to have a conversation with 911 on my phone, while I'm with the client, I do not mute myself. I be very transparent. I'm basically saying to this person, my client, I need to do what is necessary to ensure that you are safe. I'm not in a place where I can do that. As part of our safety plan, as part of like my duty to warn, my duty to protect, all those things. As it's put in the informed consent, as the outline for the therapeutic process has been, signed off on, this, if it calls for it, would be the next step. And I've had to do that on two occasions. One was with a college student who was in their dorm and had, I won't get into the details, but was very much in a place where I was kind of that last line of defense. So we had a safety plan. They had their parents listed, they had their roommate listed, they had their RA listed, their dorm resident advisor, the adults in the room in the dorm, right? So we went with the RA because they were physically closest. The roommate was in class or something. And when the RA was notified from my client via text, that they asked, like, can you come to my room? I'm having like a really, like, I need your help. Um, I was able to kind of have a conversation with the RA as I'm talking with my client as well, and just we're making sure that trade-off happens because that individual had been trained obviously as being part of what they offer for the university. They are able to kind of facilitate that next line of, okay, we're going to get you to where it is that you need to go, or we're going to be able to do some like greater assessments, whatever it may be. So lots of moving parts there. But whenever it does come to suicidality, we want to know where the client is physically located. We want to know what the direct numbers are for services in that area. So just by calling 911 in Indianapolis, Indiana, where I am, doesn't necessarily mean that it's the same 911 for where my client is physically located in another part of the state, in another state entirely, if there's a licensure, like, green light there. So we want to have local numbers listed for maybe the non-emergency police line or just emergency services. That is for that client's zip code. We want to look that up and we want to put it in their chart just to have it on standby, not because we will need it, but because if we do, we want to have it and not just be Googling. So little known fact, 911 is not 911 everywhere. Sometimes we watch TV shows and, we see the dramatized part of it where it's like, hey, 911, I need to be connected. I'm in Newark, New Jersey. Connect me with New York City. I need to get to Brooklyn. They're like, boom, done. And you're talking with someone in Brooklyn. It doesn't always work like that in real life. So, best practice, have a local, either the non-emergency police, EMS, whatever it is, for your client's zip code in their chart. We do non-emergency because they can do that quick trade-off. They can do that quick. Okay, I'm patching you through. You are local at that point. So, all right. With that said, we covered a lot. I want to thank you all. I want to thank you all for connecting with me today. We just did the Q&A. Hopefully this was beneficial. Thank you to Peter. Thank you to everybody with LEG CEU Creations. Again, my name is Christian Deck. It's been an honor hanging out with you all today, and I wish you the best as you continue today's summit.